Hello everyone, I'm Dr. Sandeep Sharma, your faculty for medicine and pediatrics, and here I am with the rapid revision endocrinology discussion. Because it's a rapid revision video, so I will not go into unnecessary details, but wherever possible, I'll try to cover all the important previous year questions, previous year topics, and we will be forming a lot of tables and flowcharts as well. So without wasting any time, let us start with the video. First of all, there are a few points you need to understand that this session is a revision session and it is not a replacement for your existing medicine notes. Still, it will give you a fighting chance and you need to practice previous year questions also alongside this session. And medicine is a vast subject. It's like an ocean. So obviously, I will be only touching upon the relevant parts. Details, obviously, we are not going to cover. But in certain topics, I will be covering some details where they are needed and if they are specifically asked in the exam. And at least 1 to 2 readings are needed because unless you revise, you are not able to going to be able to remember in the exam. And there is a Telegram group also I have formed. It's a fresh 2025 Telegram discussion group. Any doubts if you have, and for future discussions also, all the notifications I will be putting up here, and fresh quiz based upon these videos also I will be putting up there. So if you are active on Telegram, you can always join in. So let us start with the scenario based discussion. The first scenario that we are going to take up, the patient will present to you with a certain features. So what are the key words that you need to look for? The examiner will say that there is a young adult patient who's presenting with constipation and renal stone. When investigations was done, you found that the patient is having increased calcium levels with hyperparathyroidism. The patient was also having Zollinger-Ellison syndrome and prolactinoma in the brain. So what is the information that we have? We have hyperparathyroidism, which is there in the patient. So there is hyperparathyroidism. This hyperparathyroidism is the reason for producing hypercalcemia. The first two features which are mentioned here, constipation and renal stone, they are due to hypercalcemia. Second feature is these patients are having Zollinger-Ellison syndrome, also called as gastrinomas. And thirdly, they are having pituitary adenomas called as prolactinoma. So there is development of pituitary adenomas, the most common variety among them in this syndrome that we are going to take up is prolactinoma. So if you have a young adult patient presenting with parathyroid involvement, an endocrine tumor and brain tumor, which is a benign and type of prolactin secreting tumor, the likely diagnosis in the patient is MEN1 syndrome. As a case scenario, this question has not been asked in FMG, but similar question has been asked in old NEET PG exam. So I'm putting a big Q. You can get a similar case scenario in your exams as well. So remember the keywords. Let us do a rapid fire quick review of multiple endocrine neoplasia topic. MEN stands for multiple endocrine neoplasia. There are broadly three varieties: MEN1, MEN2A, MEN2B. MEN2B is also called as MEN3. First of all, MEN1 is caused by genetic mutation happening in a gene present on long arm of chromosome 11, whereas the same gene is present in MEN2A and MEN2B. So the manifestations are similar, but the type of mutation varies, which you need not remember for the exam. So what is the name of the gene? The name of the gene is red gene in both MEN2B and MEN2A, and it is present on long arm of chromosome 10. So remember, MEN1, 11 chromosome, MEN2A and 2B, 10 chromosome. What is the gene name? MEN1, it is MEN1 gene, also sometimes called as menin gene, whereas MEN2A and MEN2B, it is the red gene. If you remember, red gene is associated with multiple other tumors also. Red gene is associated with neural crest derivative defects like Hirschsprung disease also. Okay, so MEN1, MEN2A, MEN2B. Then what is the type of inheritance? They are either sporadic in nature or autosomal dominant. And then what are the alternative names? MEN1 is also known as Wermer syndrome. MEN2A is known as Sippel syndrome. MEN2B does not have a specific name. And then the most important thing, what are the manifestations? First of all, MEN1 syndrome is having a triad of three things. First of all, these patients have parathyroid adenoma. Parathyroid adenoma or parathyroid benign tumor, which is secreting large amount of parathyroid hormone, is the most common manifestation. So remember, most common manifestation of MEN1 is parathyroid adenomas, right? Second is enteropancreatic tumors. There will be pancreatic tumors happening in the patient. Gastrinomas or Zollinger-Ellison syndrome is the manifestation. And third will be brain tumors called as pituitary adenoma. They are also called as prolactinomas. Now, before I go to the MEN2A, you need to understand that there is a controversial thing you will find across the books. They will tell you that sometimes in MEN1, it is not a localized tumor in parathyroid gland. It is more of a diffuse hyperplasia in the parathyroid gland. And in fact, that is very, very common. But if they ask you the classic triad does not include diffuse hyperplasia. It includes parathyroid active tumor producing the hormone. Remember, and these are the 3 points that I have mentioned here, right? So from exam perspective, don't go into unnecessary details if they are not relevant for the type of questions which are asked. So Verma syndrome, MEN1, these are the 3 manifestations. What about MEN2A? Let us then see what is the manifestation happening in MEN2A patient. So MEN2A patient will be having development of medullary carcinoma of thyroid, which is the most common manifestation. Secondly, these patients will be having pheochromocytomas, which are benign tumors. As some 10% cases they can be malignant also, arising from the adrenal medulla. And thirdly, there will be parathyroid adenoma. And then we have MEN2B. MEN2B will have medullary carcinoma of thyroid. So this is the most common manifestation here also. There will be pheochromocytomas, but instead of parathyroid adenoma, the 2 M's will come in. You have Marfanoid habitus, so long arms, long legs, and hyperextensibility like you find in Marfan syndrome. These will be present. And mucosal neuromas, benign tumors occurring in the lips, oral mucosa, nasal mucosa, and sometimes the genitalia will be present in the patient. So these are the MEN syndromes: MEN1, MEN2A, MEN2B, also called as MEN3. What is the important point you need to remember? That patients who are having MEN1, there is no pheochromocytoma present. In MEN2A, there is no pancreatic tumors present, and the gastrinomas, the Zollinger-Ellison syndrome which occurs in MEN1, the most common site for them is duodenum. These are the 3 important points. All the 3 are MCQ one-liners. 2 of them are FMG questions. 1 of them is a older INI-CET type MCQ. Alright, so let us have a look how questions are asked to you. Very recently, last year, January 24, you had a question asked. MEN1 syndrome is associated with which of the following condition? We know that parotid tumor and gonadal tumor are not a part of any MEN syndrome. So these you can easily rule out. Now you have option number A and option number D. Even if you forget the fine details, I just told you as one-liner also that MEN1 syndrome does not have pheochromocytoma. Pheochromocytoma and medullary carcinoma thyroid are feature of MEN2. So MEN1 is having pituitary adenoma, that is prolactinoma, and that is your answer. So question asked in January 24, the answer is D. Let us move further and talk about the second scenario. Let us look at scenario number 2. Examiner will say that there is a adult patient who's having hypertension, palpitation, and sweating. The patient is also having muscle cramps with low serum potassium, so hypokalemia is there. There is high aldosterone, so hyperaldosteronism, and there is metabolic alkalosis in the patient. So what is the function of aldosterone? Aldosterone is a mineralocorticoid. It causes sodium retention and potassium and hydrogen ion loss. So that explains why there is hypertension due to hypernatremia. Hypokalemia will cause muscle weakness and cramps in the muscles, and development of alkalosis will occur because hydrogen ion is getting lost, sodium is getting retained in the patient. So whenever you have a scenario like this, you should suspect there is hyperaldosteronism. Now hyperaldosteronism can occur due to 2 causes. It can occur due to bilateral enlargement of the gland, that is a separate entity. But whenever there is bilateral enlargement, there will also be increased production of cortisol and other sex hormones as well. This patient is having only isolated hyperaldosteronism, and so it is likely to be a syndrome called as Conn syndrome. Remember, Conn syndrome refers to a condition where there is a unilateral adrenal adenoma. Unilateral adrenal adenoma which produces large amounts of aldosterone. This syndrome is called as Conn syndrome. Conn syndrome has been asked at least 3 times in your FMG past papers. So let us do a rapid fire review of the topic of Conn syndrome. So what is Conn syndrome? It refers to aldosterone production, that is hyperaldosteronism produced by adrenal adenoma. Clinically, how does the patient present? There is increased aldosterone. तो क्या होगा? Sodium retention will happen, leading to hypertension. Along with that, there is hypokalemia developing. So patient will have muscle weakness and cramps. So muscle weakness and cramps will be present in the patient. Hypernatremia, hypertension will occur because of increased sodium in the body, and muscle weakness and cramps will occur because of decreased potassium, that is hypokalemia in the patient. And ABG will show metabolic alkalosis. It's a one-liner MCQ of NEET PG already. Serum aldosterone activity in these patients will be increased. Serum renin activity will be reduced. So Conn syndrome is considered to be a type of low renin hypertension. ये अपने आप में standalone MCQ भी है. This is also a standalone MCQ. Which of the following is a relatively common cause of low renin hypertension? There are causes called as low renin hypertension and high renin hypertension that you read sometimes in cardiology. So it is a cause of low renin hypertension because renin levels are low. So obviously when you take the ratio, aldosterone to renin ratio, that ratio will be elevated. And if you find that aldosterone to renin ratio is elevated, that is an indication to perform CT scan of the abdomen in the patient, because you need to now localize and find the presence of an adrenal adenoma. Investigation of choice is saline infusion test. What is saline infusion? We give 2 liters of normal saline intravenously over 4 hours. Normal patient, if you give normal saline, 2 liter of saline over 4 hours, there is a reduction in the aldosterone levels in the body. But if there is a Conn syndrome, the aldosterone will continue to be high. So if you give 2 liter of normal saline and you find that the aldosterone levels is still high, that will indicate a positive test for Conn syndrome. What is the treatment? There are 2 types of therapies available. Initially, you will be starting the patient on drugs. The typical drug started in the patient is spironolactone. Why spironolactone? If you remember pharmacology, this is a aldosterone antagonist. But eventually surgery will be needed, and the type of surgery which is recommended, rather than enucleation, it has been found that unilateral adrenalectomy, removing a part of adrenal gland or sometimes the whole adrenal gland, is recommended in these patients. So this is a quick review of Conn syndrome. Let us have a look at the MCQ. MCQ asked in July 23. The question was, patient presents with hypertension, palpitation, sweating, aldosterone elevated, potassium levels low, likely diagnosis. It's an easy one. Patient is having Conn syndrome. Now you might think, when you get a similar case, you might sometimes get confused, ki sir, why it is not pheochromocytoma? Remember that adrenal gland has 2 parts, cortex and medulla. Cortex produces glucocorticoid, mineralocorticoid, sex hormone, and the medulla produces epinephrine, norepinephrine. If a aldosterone producing adenoma is present in the cortex, we call it as Conn syndrome. If it is present in medulla, that will cause pheochromocytoma. Pheochromocytoma will not have elevated aldosterone level. This question, the examiner is clearly mentioning aldosterone levels are elevated. And if aldosterone levels are elevated, it is not likely to be pheochromocytoma. So answer to this question is B, that is Conn syndrome. Cushing disease can have hypertension, but Cushing disease will also have hyperglycemia, purple striation, lemon on stick appearance, the typical central obesity, and so on. Those features will be mentioned. And pituitary adenoma will again not present like this. So question, July 23 FMG exam, the answer is B, Conn syndrome. Another example you can see, all of the following are seen in Conn syndrome except, don't miss out the words except. Now, muscle cramps are there in Conn syndrome? Yes, due to hypokalemia. Hypertension is there due to hypernatremia. Metabolic alkalosis is present. So what is the odd one out? A is the odd one out, and that is the answer. Also, I have told you this funda many times before also, that whenever there are 2 contradictory options and examiner is asking you to identify the wrong statement, the answer is always among those 2 options. So you have A and B option which are contradictory, so one of them is logically going to be the correct answer. So answer to this question is A, metabolic acidosis. Let's move further. Let us now look at scenario number 3. Examiner will say there is an adult patient who is presenting with postural hypotension, so BP is falling, absent pubic hair or delayed puberty, so something related to sex hormones are getting affected, and hypoglycemia and hyperpigmentation. Now, objectively look at it. There is likely deficiency of cortisol, which is causing hypoglycemia and hyperpigmentation, because cortisol deficiency will cause more ACTH production, which will stimulate the melanocytes also. So there is low cortisol, there is low sex hormone and low aldosterone, which is causing the hypotension, fall in BP. So if you have all the three layers getting affected, and if it is a newborn, you will think of a condition like CAH, congenital adrenal hyperplasia. But if it is an adult patient where all the three hormones are affected and there is a primary failure of Addison disease primary failure of the adrenal gland happening, that is called as Addison's disease. What is Addison's disease? It is the primary failure of adrenal cortex bilaterally in an adult. That is called as Addison's disease. Let us write down some one-liners. The most common cause of Addison disease worldwide is autoimmune causes. So it is mostly caused by autoimmunity. This autoimmunity can be isolated or it can be a part of a syndrome. For example, there are syndromes called as polyglandular syndromes where it can be an association. Then if they ask you most common cause of Addison disease in India it is mostly caused by tuberculosis. Then what is the hormone profile you will see in the patient? In Addison disease, all the three types of cell lineages are getting affected in adrenal cortex. So you will have cortisol deficiency. So cortisol levels in the blood will be low. Aldosterone levels in the blood will be low. And even DHEAS, the sex hormone levels produced from adrenal gland, those levels will also be low. Because cortisol is low, so ACTH in these patients will be high. That explains hyperpigmentation. And renin levels in the patient will also be elevated. When you do ABG, because there is low aldosterone, so that will show either a normal ABG or long-standing cases you will find that patient has developed metabolic acidosis. I told you the funda. Aldosterone is responsible for potassium and hydrogen loss and sodium retention. So when there is hyperaldosterone, like in Conn syndrome, you will see alkalosis. But when you have deficiency of aldosterone, you will have acidosis developing in the patient. And investigation of choice in these patients is a test called as ACTH stimulation test. ACTH stimulation test. What we do is we give injection of ACTH and 1 hour later we try to see the levels of cortisol. If cortisol fails to rise despite giving ACTH, that is indicating of Addison's disease. And what is the treatment in the patient? The treatment of choice, initially you will have to obviously give hormone therapy. So hormone replacement will be needed. What are the hormone replacements that you will be giving to the patient? You will be giving hydrocort. So what is the initial agent of choice given in all patients? Hydrocortisone. You will add a synthetic mineralocorticoid called as fludrocortisone, and you will also consider adding sex hormones depending upon the gender in the patient. And if it is an autoimmune cause, you can give a trial. You can give a trial of a drug called as azathioprine. Azathioprine has been found to be effective in some patients, not all, but some grossly autoimmune disease patients who are presenting with Addison's disease. And then we have scenario number 4. Scenario number 4 will say, now you look at the keywords, episodic or paroxysmal hypertension is there. There is profuse sweating or diaphoresis. There is anxiety, palpitation, headache, and weight loss. Weight loss indicates there is hypermetabolism happening, the metabolism has increased, and raised urinary VMA. VMA stands for vanillyl mandelic acid, which is a breakdown product of epinephrine and norepinephrine. So there is episodic hypertension, no mention of or no suggestion of increased aldosterone, and there is increased VMA, which means the catecholamines are getting produced in more. So this is a patient where you should suspect pheochromocytomas. Very, very important. Pheochromocytomas will present like this. So look at the keywords. What are pheochromocytomas? They are catecholamine producing tumors. Most common site for pheochromocytoma is adrenal medulla. Vast majority of them occur in adrenal medulla. Now, what is the pathology? When you do histopathology on gross microscopy, the tumor will appear as darkly pigmented brown-black tumor. But when you do microscopy, you will find a very characteristic pattern called as Zell-Balan pattern. If you are reading pathology, this is a pathology PYQ also. Zell-Balan pattern seen in which condition? The answer is pheochromocytoma. What is Zell-Balan pattern? Look at this histopathology photograph. Can you see that there are files and nest of tumor cells? These are called as chief cells, which are surrounded by sustentacular cells. So Zell-Balan pattern means there are files of chief cells, surrounded by sustentacular cells, which in turn are surrounded by a vasculofibrous matrix, as you can see in the photograph. So this type of pattern is typically called as Zell-Balan pattern. Now, what is the site of metastasis? If it is found to be metastatic, remember that not all patients are metastatic. Only 10 to 12% are found to be metastatic. But if it is metastatic pheochromocytoma, mostly that metastasis will go to lymph nodes, followed by liver, followed by bones, followed by lungs in the patient. And there is also a rule of 10. Rule of 10 is a Ames MCQ. So rule of 10 says 10% of pheochromocytomas are extraadrenal, 10% are found in children, 10% occur in families, so positive family history is there, 10% are found to be malignant, 10% are associated with MEN syndrome. Remember, MEN 2A and MEN 2B you find pheochromocytoma, not MEN 1. And 10% are incidentally detected, so they will be silent before they present suddenly, or when you are evaluating for some other reason, you chance across a pheochromocytoma. What are the investigations? Two types of investigations are done: blood and urine. On blood, you will find increased levels of catecholamines, and you will find that there is increased levels of free metanephrines. So plasma free metanephrine levels will be increased, and in fact increased free metanephrine in blood or serum is considered to be a screening test for pheochromocytoma. I'm putting a star here, potential MCQ point. Regarding urine, urine will show increased levels of catecholamine release, as well as increased levels of VMA. VMA stands for vanillyl mandelic acid. But obviously it's a tumor, so you need to do abdominal imaging as well. So when you do abdominal imaging, you will do either CT or MRI. MRI is more sensitive, especially if it is an extraadrenal spread that you are suspecting. The sign that you find in these patients, putting a Q on top of it, light bulb appearance. Light bulb appearance will appear something like this. At the arrow is showing you a typical pheochromocytoma happening in adrenal medulla, where it will appear as a bright rounded object similar to a bulb. We call it as a light bulb appearance. And for checking the spread in suspected metastatic tumors, you can do PET scan using gallium-68 or F18 dopa. You can do a MIBG scan, or you can do a somatostatin receptor scan using indium-111, and finally you can do a technetium 99M per technetate scan as well. And treatment in the patient is always surgery, but anything important in surgery, the mortality is increased during operation if you do not give alpha and beta blockers. So what is mandatory in surgery? Pre-operatively, before you start surgery in the patient, because when you handle these tumors, there will be sudden release of epinephrine, norepinephrine, and that can cause fetal arrhythmias on the operation table. So pre-operatively, alpha plus beta blockade is mandatory. And if you look at past papers, you will come across this as a one-liner question. You will not come across this in medicine. You will find it either in surgery or in anesthesia. So preoperative alpha plus beta blockage is mandatory. And look at the MCQ asked on this. August 2020, 35-year-old recently divorced male is having palpitation, headache, diaphoretic episodes on a recurrent basis. He has visited psychiatrist multiple times and there is no benefit. Maybe it is not due to a stress or psychological illness. What should be the next step for management? Check for catecholamine levels to rule out pheochromocytomas. Pheochromocytomas are sometimes missed because we keep attributing it to lifestyle changes or some familial hypertension or some other reason or some kidney disorder. episodic nature should raise the suspicion. One possibility, one DD should always be pheochromocytomas in such patients. So remember, for the exams, for MCQs, if there is sustained hypertension with raised sodium, raised aldosterone, low renin, you should suspect adrenal adenoma, that is Conn syndrome. And if the question says episodic hypertension, headache, diaphoresis, normal or low aldosterone, or if they don't mention about aldosterone, you should suspect pheochromocytoma. This is very, very important. And if you remember this funda, potentially you can get a question based upon differentiating between the two conditions. Let us now have a look at scenario number 5. Now, scenario number 5, examiner will say that there is an adult patient who's presenting with moon-like face. You already know the answer. So moon-like face, centripetal obesity. Centripetal obesity means the central body is obese and the peripheries are thin. This is also sometimes called as lemon on stick appearance. Lemon on stick appearance. And the patient is having hypertension, hirsutism and cataract. The hypertension not only involves systolic, it is the diastolic hypertension which is very characteristic. And cataracts, whenever they occur, they tend to involve the posterior part of the lens. So posterior lenticular opacities are found to be very characteristic. With or without other things like hyperglycemia, peptic ulcer and CNS manifestation, if you have a presentation like this, the likely diagnosis is going to be Cushing syndrome. So let us do a quick review of Cushing syndrome. First of all, what are the causes of Cushing syndrome? There is always a lot of controversy on this. So what I have done is I have gone through the books, and because it's a rapid revision, to save your time, I am going to show this handmade flowchart. This is my handmade flowchart. I don't have a great handwriting, but still you will be able to understand the key points here. I will be saying it out. You will be getting, you can pause the video and write down these causes or revise these causes. What is Cushing syndrome? Cushing syndrome refers to, I will first of all write here in the bracket, sustained chronic elevation of glucocorticoids in the body. That syndrome arising because of increased glucocorticoids or corticosteroids in the body is called as Cushing syndrome. Now there are two types of causes, exogenous and endogenous. Exogenous means the steroid, the excess glucocorticoids are coming from outside the body. They are also called as iatrogenic, and this is the, look at this chart. This is the overall most common cause. And from where the steroids will be coming? When you take steroid intake. For example, for any inflammatory condition, if you are giving steroids, or any renal condition, nephrotic syndrome, you are giving steroid, that is going to cause Cushing syndrome in the patient. The clues, it is exogenous steroid, will be history of steroid intake due to a underlying inflammatory disorder. There will be elevated cortisol levels circulating, but the ACTH levels will be suppressed in the patient, right? That will be the clue. On the other hand, if there is endogenous will mean exogenous steroids are not being given. The body is itself producing large amounts of corticosteroid. So it can be of two varieties, ACTH dependent, which are 90%, and ACTH independent, which is 10%. ACTH dependent one will be having increased ACTH level. So I'm writing in bracket, these are the patients who are having increased ACTH activity. On the other hand, ACTH independent will be having a normal to low levels of ACTH. So ACTH independent causes are less common. Adrenal cortical adenoma or adrenocortical carcinoma will be the causes. When you talk about ACTH dependent causes, you have further two varieties. Either pituitary is producing ACTH, we call it as pituitary adenoma, which is 75% cases, or there is an ectopic ACTH production. Ectopic ACTH production is typically seen in patients with oat cell carcinoma of lung. These patients, male and female, are equally affected. On the other hand, pituitary adenomas are more common in females, and the word used here is Cushing disease. So you need to distinguish Cushing syndrome from Cushing disease. Cushing syndrome is a broad category which has multiple reasons. If Cushing syndrome occurs due to overproduction of ACTH by a pituitary tumor in the brain, the term used is Cushing disease. So Cushing syndrome, Cushing disease, they look similar, but there is a fine distinction between them that you need to remember. Right? Now, a lot of questions and tough questions are asked. clinical approach and how you are going to manage the patient. So again, for this I have made a handmade chart which I will be explaining as I write. So whenever there is a clinical suspicion of Cushing syndrome, when will there be a clinical suspicion? The patient will be having typical features like central obesity, hypertension, and hyperglycemia along with hirsutism. You will think of Cushing syndrome. First of all, we need to do screening in the patient. And screening as well as confirmation whether Cushing is there or not, three options are available. You need to understand many of the guidebooks wrongly say that all three have to be done. No, any one out of these three can be done according to Harrison 22nd edition, Harrison 21st edition. And it says that if there is a patient having Cushing syndrome, first of all, you can check the 24-hour urinary excretion of free cortisol. If the value is increased equal to or more than 2 times the normal value for that age and range, that is also a positive screening test. Or you can do a dexamethasone overnight suppression test. This test, because we are using 1 milligram dose, we also call it as low dose dexamethasone suppression test. You need to understand there are two types of dexamethasone suppression tests done in Cushing syndrome. One is low dose, where 1 milligram dose is given. One is high dose, where 8 milligram dose is given. Low dose is done for identifying whether Cushing is there or not. And high dose is done to check for the cause of Cushing syndrome, right? So low dose dexamethasone, how do? We give 1 milligram of dexamethasone overnight about 8 p.m. or 9 p.m. and then at 8 a.m. in the morning you check for plasma cortisol. In a normal patient, the plasma cortisol level should fall down. But if the patient is having sustained cortisol more than 50 nanomoles per liter or still more than 2 times at 8 a.m. in the morning, that will be a positive test. Or if you find that the midnight salivary cortisol is more than 5 nanomoles per liter, that is also suggestive of Cushing syndrome in the patient. So if any of them is positive, that indicates Cushing syndrome. Now this third point is very, very relevant to us. Why it is relevant? Because in Cushing syndrome patients, there is a loss of diurnal variation of cortisol. We all know that cortisol levels tend to dip late at night and early morning, late at night hours, and it tends to rise in the daytime. But in Cushing syndrome patients, they will always be elevated, and when you check the midnight level between 12 to 3, normally the levels are low, but if the circulating levels are found to be high, that is again an early clue. In fact, this is considered to be the earliest evidence biochemically that the patient is having Cushing syndrome. So examiner can just ask you which is the earliest evidence there is a loss of diurnal variation of cortisol. So what are the three tests that we do? Urine free cortisol, low dose dexamethasone suppression test, or midnight salivary cortisol. Any of them present, patient has Cushing syndrome, right? If there is Cushing syndrome, what is the next test that you do? You check for the plasma ACTH level. Now plasma or blood ACTH level, there will be two possibilities. Either ACTH is normal to increase, that will indicate a ACTH dependent cause, or it is decreased, that will indicate ACTH independent cause. ACTH independent cause, you will do CT adrenal because the causes are adrenal hyperplasia or unilateral adenoma. For that, CT scan needs to be done. On the other hand, if there is ACTH independent cause, you will do one out of these three tests, either MRI pituitary or CRH test. CRH is corticotropin releasing hormone, or you will do high dose dexamethasone suppression test. I told you the funda. For identification of cause, we do high dose dexamethasone suppression test, and the dose here will be 8 milligram. Now there will be two possibilities. If the MRI shows a pituitary tumor, or there is a positive CRH test, or cortisol is suppressed by giving dexamethasone, it is decreased by giving high dose dexamethasone, the likely diagnosis in the patient is Cushing disease. That is, patient is having a pituitary tumor which is causing Cushing syndrome. On the other hand, if you find that MRI is negative, CRH test is negative, and high dose dexamethasone suppression test is negative, that is, cortisol and ACTH concentration continue to be high despite doing the test, it was high before also, high after also, then you will suspect the patient is likely having ectopic ACTH production. And I have put a small q because a very similar question based upon this funda was asked in the entrance exam recently. What question? I will just show you in some time. So this is the approach that we take in the patient. It's a tough thing, and trust me, this is the toughest thing that you can remember for your exam. But tough doesn't mean it is less important. Tough means it is relevant for your exam. Now, how you are going to treat the Cushing syndrome patient? First of all, you have to treat the cause. If there is a adenoma, pituitary adenoma is there, you will do transfemoral resection of the pituitary adenoma. Or if there is an adrenal cause present, then you will do adrenalectomy on the affected site. Then secondly, you will be using drugs which oppose cortisol action. The drugs which are approved for use by FDA, they include metirapone. Yaad karna padega, you have to remember. Metirapone is a drug which inhibits 11 beta hydroxylase enzyme, and so it reduces cortisol production. Secondly, ketoconazole, it reduces steroidogenesis at multiple levels in the adrenal glands. Third is mitotane, which again reduces cortisol release. And fourth will be Paceriotide, which is a somatostatin receptor antagonist, and this is the drug which is useful in Cushing disease. What is Cushing disease? The pituitary tumor which is causing disease, which is not surgically resectable. So if the tumor is not surgically resectable and it is causing Cushing disease, then Paceriotide, which is a somatostatin receptor agonist, can be used in such patients. Now, how questions are asked? Have a look at MCQ January 24. Chronic smoker presented with abnormal weight gain. It was one of the tough questions asked in January 24 FMG exam. Chronic smoker presented with abnormal weight gain, hyperglycemia, hyperpigmentation. See, if there is a smoker or there is a tumor, normally there should be weight loss happening. If weight gain is happening, that indicates likely Cushing syndrome, some metabolism is getting slow. So abnormal weight gain, hyperglycemia, hyperpigmentation pointing towards Cushing syndrome. High dose dexamethasone suppression test was done. Before and after the test, ACTH was found to be consistently high. I told you, if the high dose dexamethasone suppression test is negative, means it continues to be high before and after, you should always suspect a ectopic cause. And what is the common ectopic cause of ACTH production? Oat cell cancer of lung, and oat cell cancer will be common in a chronic smoker. So clinical diagnosis in the patient is ectopic source. Now you might get confused, sir, how to approach such question. There is another approach you can remember. This is the simpler one. So you can remember like this, that first we do a test called as low dose dexamethasone suppression test. Low dose dexamethasone suppression test. What is the dose that we give? 1 milligram in such patients. When you do this test, there are two possibilities. If cortisol is suppressed, cortisol gets reduced, that is considered to be normal patient. But if cortisol fails to get suppressed, cortisol is still increased, you will suspect patient is having Cushing syndrome. Okay. Then for identifying the cause, you do the high dose dexamethasone suppression test. High dose dexamethasone suppression test. And what is the high dose that we use here? We use 8 milligram of dexamethasone. Now again, there are two possibilities. Either cortisol is suppressed, cortisol is decreased. That will indicate Cushing disease in the patient. Cushing disease indicates there is a tumor in the brain which is producing it. If you find that the cortisol level is increased, then you look at further whether ACTH is high or normal. If ACTH is also high, that will indicate ectopic cause. And if you find that the ACTH in the patient is low ACTH will indicate endogenous cause, but it is ACTH independent, so you will think of adrenal cause as the answer. This is a second approach, but for some questions this approach also works. So ideally speaking, the first approach I told you, that long approach, you need to remember it. If you are running short on time, I am giving you an option that this approach will also work for if you are Suppose if you have not read endocrinology at all and you still want to have a fighting chance or sir wo nahi ho raha last 1 week or 10 days mein, go for this particular thing, and this will also be helpful in similar questions. Okay, now let us have a look at another question. MCQ January 23. Most common cause of Cushing syndrome in a 68-year-old male. Now they have not mentioned about exogenous cause, so the most common cause will be endogenous. 70 to 75% causes are caused by pituitary microadenoma, which causes Cushing disease, and so this is your correct answer. Explanation we have already done in the previous topic. Let's go to the next scenario. Next we have scenario number 6. Scenario number 6 will say that there is a patient who's having sudden flushing lasting 5 minutes. Secondly, patient is having watery diarrhea. Third, there will be wheezing episodes resembling asthma. And fourthly, there will be, this is a very important clue, urinary 5-HIAA. HIAA stands for hydroxyindole acetic acid. It's a breakdown product of serotonin. So basically there is increased serotonin in the body, which is causing flushing, diarrhea and asthma-like symptoms. So patient is likely suffering from carcinoid syndrome. Is there a question on this? Yes, a case scenario question has been asked. So please remember these key points of manifestation very, very clearly. What is carcinoid syndrome? It is a tumor-related syndrome which occurs due to increased serotonin. Serotonin is also called as 5-hydroxytryptamine production from neuroendocrine tumors of small intestine or appendix. Flushing can be triggered by alcohol, stress, exercise, or cheese ingestion in the patient. Then investigation of choice in such patients will be checking the urine for 24-hour collection you do for urine, and then check the 5-HIAA levels. If the levels are above the age and gender related threshold, there are tables, normograms available that is virtually diagnostic of carcinoid syndrome. Now there are two crises that you need to remember, two fancy terms related to it. First of them is carcinoid crisis. Many times carcinoid crisis will cause, what is carcinoid crisis? Many times you will find that carcinoid syndrome is being produced by a tumor. When you try to do surgery in the patient, during manipulation, there will be occasional release of 5-hydroxytryptamine. This can cause sudden high BP or sudden low BP, which can be life-threatening and can cause intraoperative mortality. So that is called as carcinoid crisis. And second is carcinoid heart disease. The circulating 5-hydroxytryptamine has a tendency to cause regurgitation and fibrosis. So which is the characteristic lesion? Tricuspid regurgitation is the characteristic lesion. In long-standing cases, right-sided valve fibrosis can also occur. Remember that left side is relatively spared. And which drug can mimic the fibrotic, cardiac fibrotic action of carcinoid syndrome? It is a drug called as fenfluramine. This is your NEET PG one-liner question, can be a one-liner question in your FMGE exam also. And what is the treatment in these patients? You will have to identify the cause and resect that cause. Apart from that, medical therapy will be in the form of somatostatin analogs, octreotide and lanreotide. Both of them have been found to be useful. Let us have a look at the question which was asked in July 24. Which of the following is not correct about carcinoid tumor? Tricuspid regurgitation seen? True. Asthma-like symptoms can occur? True. Flushing is common? True. Urinary 5-HIAA is not normal, it is elevated, and so they are asking not correct, and so option number A is the correct answer. Now there are two MCQs you can get confused sometime. Look at this. Investigation of choice to identify carcinoid syndrome will be 24-hour urine for 5-HIAA. Okay, if they say you have to identify the pancreatic, you are suspecting a pancreatic neuroendocrine tumor producing carcinoid, then what test you will do? Then you will go for gallium dotate PET scan, also called as somatostatin scintigraphy, and this was the MCQ which was asked in January 23 FMG exam. To identify carcinoid, there is a different test, it's a urine test, but for localization of the cause you will have to do a imaging test, and that imaging test will be gallium dotate PET scan. Okay, gallium dotate PET scan. Even if you forget it is 68 gallium, simply remember gallium dotate PET scan, and that will be the answer. Moving further, we need to discuss a few points related to pancreatic neuroendocrine tumors. What are the important pancreatic neuroendocrine tumors? The first one is gastrinoma. Gastrinoma is the one which is also called as, it produces the typical Zollinger-Ellison syndrome. Most of the gastrinomas, they occur in the gastrinoma triangle, also called as Pesaro's triangle. What are the boundaries of Pesaro's triangle? This is your surgery MCQ. We are doing integrated thing. My purpose is to cover maximum ground in the shortest time possible. So boundaries of gastrinoma triangle include: number one, junction of cystic duct and common bile duct. Second landmark is junction of head and neck of pancreas. And third hallmark is junction of inferior border of or inferior margin of second and third part of duodenum. So it is something like this. I am making a very crude picture. So CPD. This is how you remember it. So cystic and common bile duct here, then pancreatic head and neck body here, and second and third part of duodenum here. This is the site where maximum gastrinomas tend to occur. Gastrinomas are characterized by increased production of gastrin that will produce Zollinger-Ellison syndrome, and the patient will have peptic ulcer, GERD, and diarrhea. And fasting hypergastrinemia will always be present. Fasting levels of gastrin are elevated. Although surgery is advisable, but surgery is not always possible. And so therapy of choice, initial therapy of choice are drug therapy. In drugs, it is the PPIs which are hugely effective. PPIs are the drug of choice. Some patients which are refractory to PPI can respond to octreotide as well. The second pancreatic neuroendocrine tumor review, that the tumor includes insulinoma. Insulinoma presents with, it produces a large amount of insulin. So obviously it will be causing hypoglycemia, and patient can present to you with confusion and headache. In fact, it can resemble neuropsychiatric symptoms also sometimes. Second, these patients will have weight gain. We know insulin is a anabolic hormone, so weight gain will be there. And when you check for the circulating levels, circulating blood levels of fasting levels of insulin, proinsulin, and C-peptides will be elevated. And the best investigation for localization, this is a INI-CET MCQ to identify insulinoma. It is endoscopic ultrasound. What is the treatment? Treatment of choice these days is everolimus followed by diazoxide. There is not a very popular, but one guidebook in the market related to FMGE past paper, where theory part they mention diazoxide as the drug of choice. No, the drug of choice is everolimus, and this is clearly mentioned in the text of Harrison. So always remember the latest things. And enucleation, which is a type of surgery, needs to be done in severe cases. And then we have other pancreatic neuroendocrine tumors. What are the key words you need to remember? So which pancreatic neuroendocrine tumor is associated with dermatitis? What is the type of rash? Necrolytic migratory erythema. There is a one-liner question asked in past FMG exam. It affects groins and buttocks. It is classically seen in patients who are having glucagon oma. So these are the tumors which produce large amount of glucagon. So we call them as glucagonoma. Secondly, it can, if the question says there is diabetes mellitus with steatorrhea, with gallbladder disease, and with diarrhea, you will think of somatostatinoma. Here the tumor cells are somatostatin type of cells, somatostatin secreting cells. And third, if the examiner says watery diarrhea, hypokalemia, achlorhydria, this is also written as WDHA syndrome. So watery diarrhea, hypokalemia, achlorhydria will be suggestive of VIPomas. There is excess VIP, vasoactive intestinal peptide production in the patient. So VIPoma should be suspected. VIPoma, this syndrome is also called as Werner-Morrison syndrome. Fine details, manifestations, metastatic or not, treatment of choice, they are unlikely to be asked in your FMG exam. At least you should be able to identify what is the case that is being talked about. Now scenario number 7 is a brief overview. Examiner will say that there is an adult patient who's presenting with abdominal pain, renal stone, nephrocalcinosis, so hypercalcemia features, and there are brown tumor-like lesions happening in bones of jaw, clavicle, ribs, pelvis, hands and feet. These are the clues, the keywords which will indicate primary hyperparathyroidism. So a case scenario question has been asked on this. Second thing that the examiner might be interested in knowing is how to localize where exactly the lesion is present, whether all parathyroids are affected or a small lesion is there, or maybe there is an ectopic parathyroid where these tumors, tumors are there producing primary hyperparathyroidism. For that, we do investigation of choice preoperatively, that is System-B scan. So technetium 99M System-B scan with single photon emission CT called as SPECT scan is performed for localization. Treatment details you need not remember, only this I am putting a star, potential MCQ, this one is a already existing MCQ you need to remember. And I stop this video here. The reason is the video will become too big and that will affect your concentration also, and that will affect your revision part cycle as well. So in this video I have talked about the adrenal endocrine disorders mainly, and we have talked about the carcinoid syndrome and pancreatic neuroendocrine tumors. Second part of endocrinology video, which I am recording right now and uploading today itself on the YouTube channel, will be having the thyroid disorders, and our emphasis will be on diabetes mellitus, diabetic ketoacidosis and related points. So don't miss endocrinology part 2 video as well. Thank you so much.